we'll start and talk about lymphedema today. I come from Helsinki, from the University Hospital here in Finland. So a little bit about, I don't know how much all of you know about lymphedema, but we can classify it in many ways. Usually we tell that the patient has lymphedema if there is a more than 10% volume difference, and we can classify it traditionally as mild, moderate, or severe. The International Society of Lymphology made a consensus a couple of years ago where they actually staged it in 4 stages, adding a stage 0, which means subclinical, meaning that the patient has some uncomfortness, and with some technical measurements, we know that they already have a beginning of a lymphedema. These stages are quite important when we see the patient initially, because they help us to make the decision on what kind of treatments we might be able to offer. So etiology varies. We know that some people have primary lymphedema or have a predisposition for lymphedema. Their lymph vessels or lymph nodes are just not normal. And this is a big entity of which we actually still know very little about. Most of the patients that you, as surgical oncologist, will see will probably have secondary lymphedemas that can be acute due to maybe a new tumor progression, or chronic, usually as a sequelae of the treatment. Primary lymphedemas can be anatomical or functional. There can be problems in the valves, backflow, and there is also an entity of patients who have both. Here is a nice chart that some colleagues from England made, which one can have in the pocket, about how to go about diagnosing a primary lymphedema. It might lead us to some genes that can help understand that certain patients' problems. Why I'm showing you this is because in secondary lymphedema, some patients also can have a primary underlying problem. Secondary lymphedema typically arises postoperatively or post-irradiation, but also post-infection, and can be a combination of all of these. In the Western world, the most typical cause of lymphedema, all in all, is obesity and inactivity. Breast cancer-related lymphedema is what you participants probably see most, and that affects quite a lot of women every year. More than 300,000 women develop lymphedema yearly, and of course all of the general surgeons, breast oncologists are working on how to prevent that, and the decision making on whether or not to go for a axillary dissection is now questioned more and more often, and tumor biology can be taken into account. We know that after axillary dissection, almost 20% of the patients will eventually have lymphedema. So it's a major sequelae, because these women are going to maybe live for decades. They might not be dying from breast cancer anymore, as was the case before. So now the treatments have to be less severe. Unfortunately, even after sentinel node biopsy, it can occur. And why? This a picture shows that in some patients, the nodes coming from the arm can join with the nodes coming from the breast quite early, even at level 1 or level 2, which are often cleared during axillary dissection. Risk factors for developing lymphedema, it's quite, let's say that the strongest connection is with obesity. The bigger the lady, the more chance of developing lymphedema, and partially maybe due to the fact that surgery is more difficult, but mostly because the small, very, very thin lymph vessels can get compressed in a very chubby arm. In fact, that is by far the most important risk factor. But of course, the severity of the cancer, which makes sense to all of us surgeons, is that the more you have to operate, the more lymph nodes you have to take, the more the risk, of course. The need for mastectomy is an independent risk factor, but probably also related to the severity of the disease. Like I hinted before, in the recent years, scientists have found a connection between primary lymphedema and treatment-associated lymphedema, so that actually some women might be more prone to develop lymphedema after surgery. And these genes, for example, have been identified as predisposing factors to developing post-mastectomy and accelerated evacuation lymphedema. So hopefully in the future, we'll be able to identify these patients beforehand so that we know which patients have a higher risk, and then we might be able to prophylactically prevent lymphedema in those patients, be more careful about the axillary surgery, or also go for prophylactic lymph node transfer, for example. There are also other risk factors. Anatomy varies. People have different lymphatic flow. Some of us have alternate pathways that go directly to the supraclavicular nodes. They're called Kaplan and Mascanini pathways, and these pathways can also open later in case the lymph nodes lymph flow to the axilla is blocked. And we also have been able to see in different lymphedemas, not only in breast cancer related, that the patients who have more risk for infections then create like a vicious circle. When you get infectious, the lymphedema gets worse. So different patients, we need lots of different solutions. And for a clinician to evaluate what to offer that patient, we of course need to understand a little bit of the etiology, and like in any surgery, consider the possible comorbidities that that patient has that might affect surgery. But in lymphedema, it's very important to assess the duration of lymphedema, because with time, the lymph vessels suffer more, so that an early lymphedema might have a better chance of recovering from surgical interventions than a late lymphedema. Also, the amount of infections, cellulitis, erysipelas, if that patient has had those, that might have damaged the lymph vessels permanently. Of course, age and body type are to be considered, and then what is the patient really looking for? What kind of risks and surgery they want to undergo, if they want a fast solution or they want something more permanent but with a slower recovery. So remember to ask questions and send comments anytime. Assessment of lymphedema is not easy. Traditionally, it's measured by circumference, by tape measurements, but this, of course, is very user dependent. And if ideally you have a physiotherapist that can regularly do these measurements, it's more reliable, because measure reliability is low. There are also machines for this that provide some data, but the golden standard is the water displacement. But this is, of course, not easy to arrange in an outpatient clinic. Then there are many other machines for measuring the quality of lymphedema, bioimpedance, tissue water content measurements, and also in MRI you can assess the thickness of the subcutaneous tissue and the water content. For function, we can assess the lymph vessels by lymphoscintigraphy, which is mostly available in all the cancer centers, but it only shows us whether or not the patient has functional lymph nodes. It doesn't necessarily give us an anatomy of the lymph vessels. So an MRI, a special lympho-MRI, is would be the best way of assessing but of course a more expensive and more time-consuming way of examining, and not available everywhere. Subclinical lymphedema we can assess with tissue quality tissue water content measurement. Some of the patients after axillary surgery might have just nerve damage and might have the feeling of lymphedema. In our country, currently, most of the patients, and I think this is quite similar in all of Europe, mostly just undergo conservative treatment, but more and more will be referred to our center for operative treatment also. What is the conservative treatment? The key point is weight control. At the moment, we don't offer surgery to patients who are overweight or whose BMI is more than 30. Then we stress that they need to do exercises, because the muscle pump also empties a part of the lymph flow from the arm, and especially swimming, water sports are quite useful, but any kind of exercises are better than nothing. Then the regular use of compression garments or bandaging is really important, and it's important that they are changed at regular intervals so that they're tight enough. Manual lymphatic drainage is useful when measuring the new garment. So a set of a reduction phase of two weeks of manual lymphatic drainage to make sure that the extremity is thin, and then the measuring of compression garments is the best way to ensure that the patient has suitable garments. For surgery, I will undergo different methods, but we can divide them in two sections, potentially curative or just simply palliative surgery. And if the patient wants a very fast cure, has a very long-standing fibrotic lymphedema, we go for these palliative measures. None of them are curative as such. We cannot promise a cure for these patients, so we need to be very careful on what we promise, but we can help them. So, like I already said, we don't operate people nowadays of BMI less than 30, and patients who are already undergoing strict conservative treatment with garments and infection control. There are in these potentially curative options, I will now discuss lymphatic anastomosis, lymph node transfers. If in a lymphoscintigram preoperatively we see active nodes, we always first enhance the conservative treatment. But if there are no working nodes and the patient has an early lymphedema, we might consider these potentially curative treatments. But if it's a long-standing stage 3, we go for the palliation. And please remember to ask and send questions. Liposuction was popularized by Håkan Brorsson from Malmö, Sweden, for the treatment of lymphedema, doing a very aggressive liposuction so that the extremity becomes even thinner than the contralateral arm. In his very long 20-year follow-up, he can show that if he does a liposuction and the patient is committed to wearing the compression garments, they can have a long-term effect, but they must wear the compression garment always. If you do liposuction and a patient doesn't wear the garment, unfortunately, the lymphedema will recur. Here are just some patients of the lower limb, patients who had gynecological cancers, and this patient has had liposuction, and here's a 7-year result. So if she wears the garment, the result stays. In some patients, we also have so much skin and such a large quantity of tissue that we need to combine with excisions, and then I usually combine with liposuction to make everything softer. This is typically in patients who are not compliable otherwise. Of the potentially curative, I will discuss the lymphatic-venous anastomosis and the lymph node transfers. Lymphatic-venous anastomosis have been proposed already in the 80s, but in those days, the instruments and the threads were just simply too big for making these anastomoses. Myself, I started in the beginning of 2000s. 2001, I did my first, but even then, I didn't have the proper instruments. It was in the late 2000s only that we got the availability of 11.0, 12.0 thread and the instruments that we need for this kind of surgery. I like to do mine in local anesthesia, sometimes in general if the patient's afraid, but it takes about 2-3 hours to do surgery like this, and most of the patients choose this surgery because it's local anesthesia. We use the method of ICG fluorography using indocyanine green, which we inject subcutaneously in the fingers and in the thinner, and this goes in the lymph vessels, and we can on the table with the ICG camera see these lymph vessels and mark them, and then make small incisions on top of the lymph vessels, and using a microscope suture the lymph vessels to veins. We use very small veins that should not have a lot of backflow, so actually capillaries are the best, or some side branches, because if you try to do this to a very big vein, then the patient will have a lot of backflow, and it's possible that the anastomosis will thrombose. Sometimes we see a situation like this where we can't see clear pathways, but we see what our Japanese colleagues call the snowfall or the stardust phenomena. And here we see only dermal backflow, so there are no functional lymph vessels anymore, and then we convert to liposuction. So, any questions? I hope that you're sending some questions. The lymph node transfer was also not is not a young idea. In fact, I've just recently seen one patient who had a lymph node transfer in our unit already in the 80s, but was really advocated by Corinne Becker from Paris, who was the first to publish her long-term results, and now has become a very widespread, very interesting surgery that is still partially, we can say, experimental, because we do lack really long-term studies. The idea is to harvest lymph vessels or lymph nodes from an area that provides a not so risky donor site. Usually we take from the inguinal area the abdominal lymph nodes, not the nodes of the lower limb. There are many different donor sites that have been proposed. The inguinal nodes are the most common, but for lower limb lymphedema, we can also use the lower thoracodorsal nodes, some mental or supraclavicular nodes. And there are also different schools. I myself like to put the lymph nodes in this area of the scar and release the scar, but there is a lot of colleagues from Asia who prefer to put the lymph nodes distally. And there is no consensus about whether or not to combine with the lymphatic-venous anastomosis, and how soon after the occurrence of lymphedema this is still efficient. In our hospital, the method I use is to use a groin flap with lymph nodes, so that we have also a skin island that we can monitor, and also the skin island carries a lot of subdermal plexus lymph vessels, and this has is taken using reverse sentinel mapping so that we make sure that we do not include the lymph vessels of the lower limb. And here are some pictures of how to harvest that flap, also with some fat and skin. We like to combine it with breast reconstruction if possible, and this is of course an easy way to start, because if the patient's going to have a flap anyway, you might as well include the lymph nodes, and you can use different flaps as carriers. Here, positioning the lymph nodes in the axilla and the flap, you can use whichever recipient vessels you choose. Here are just some of my own results that I looked at a group of 20 patients with 3-year follow-up, and I could see that most of them at 3 years were able to leave out the garment. And for the lymphaticovenous anastomosis, unfortunately, this is not the case. It's more effective in the distal lymphedema. And here is one patient at 3 years, but what you can see is that even if the patient's been able to leave out the garment, the arm is still large. It is because from the studies of Håkan Brorsson, we know that lymphedema induces fat growth in the arm, and therefore her arm has become fatter than the other side. And after 3 years from the lymph node transfer, we usually combine a liposuction to make that arm the same size as the other one. I think axillary scar release plays a big role, and US surgical oncologists probably agree that it can also be a combination of the scar compressing the axillary vein and the obstruction of the lymphatics. And in fact, I found a very old study from a Finnish medical paper from 1916, where already then a general surgeon suggested that it might account for even 20% of the lymphedema. And it is also my clinical experience that about 20% of the patients get some immediate benefit from the scar release. And here again, remember to send in questions. In the lower extremity, it's much more open questions. We don't know yet where to put the lymph nodes, and I think this is still experimental surgery, but it's something that we need to offer our patients, because otherwise we will never know. Genital lymphedema is a very interesting topic. Many patients after gynecological, urological cancers and after infections come to us, but this is mostly palliative surgery at the moment. So again, the same slide that I showed you before, if we do detect in the preoperative lymphoscintigram some active nodes, we just enhance the conservative treatment. But if the patient doesn't have any working nodes, we can suggest a potentially curative surgery to stage 1 and 2, but in stage 3, it is my observation that palliative surgery is the best. And here a summary like this: the lymphaticovenous work well for those patients with very distal lymphedema in the palm or around the wrist. The lymph node transfer is for stage 1 and 2 patients, but in stage 3, liposuction is the best. In the future, I hope that we can better identify the patients that are at risk, and maybe as general surgeons, you can also look into using reverse axillary mapping in a cancer operation situation to avoid including the nodes of the upper extremity. We have started last year also a clinical study using VGFC, which is a growth factor for lymph vessels, and trying to enhance the results of lymph node transfer, and hopefully we'll get some results in the upcoming years. The trend in the world is towards individualized treatment, and many of the colleagues are now proposing a combination of lymph node transfers and lymphaticovenous anastomosis, or lymphaticovenous anastomosis and liposuction. And I think this is the way the world is going towards, that we need to offer several different methods for the patient, but we can help them, although unfortunately at the moment we cannot yet cure them. So prevention, of course, is the key. Thank you very much. Now,
thank you very much,
think it's
Sinikka.
time. Yes.
Can you hear me well?
Yes, perfect.
Okay. Thank you very much for your brilliant presentation. It's really put all together so much information, and hope it will be very helpful for our viewers. We're still waiting for questions from the viewers. In the meantime, I will start with my questions. So, what is the funding of lymphedema treatment in Finland? Is this covered by the national?
It's covered by the national, as it's a cancer, it's a sequelae of cancer, especially when it's a sequelae of cancer, it's covered by the national health insurance. So the patients will get the compression garments from their primary healthcare physician, and also the reduction phase lymph therapies at least once or twice a year for the measurement of the garment. However, for patients who don't have a clear diagnosis, it's sometimes more difficult to get the funding, because if you don't have like a clear disease, when it's an unknown origin. But yes, and all the surgery, of course, is covered by the national healthcare.
Okay. That might be issue in many of other countries, so you're quite lucky. So how many patients you're treating with lymphedema surgically, let's say on a monthly basis? Is it something very common that you see?
Well, since a couple of years, we put together a lymphedema clinic. So we do together with 2 other colleagues a special outpatient clinics for lymphedema every second week, so twice a month.
That's great.
So then from that population, I would say that we do some lymphedema surgery on a weekly basis. Maybe breast reconstruction with lymph nodes is the most common, but liposuction also. So usually something every week, sometimes 2 cases a week.
Okay. So I had a couple of questions from my plastic surgeon colleagues. Can you tell us something about timing? Let's put it like this: when is the right time to do this type of surgery? You mentioned first, of course, you start with conservative treatment and you use them as much as you can. But then once you see that the disease kind of progress, do you need to do something else, or you can go straight for the surgery, given the fact that the patient lose a little bit of weight and use the compression garments and so on? Is there anything else that you recommend before surgery?
Well, I think it's very important to be very honest with the patients and tell them that we cannot promise in an individual patient that they will have a perfect result. We only have like statistics that quite a large percentage of the patients will benefit, but how the result will be in that patient, so that they don't have too high expectations. But I think this goes for any kind of surgery. It's very important to be honest about the results, and also to discuss with the patient if they want a fast relief of the size and the heaviness. They might want to just go for liposuction in any case if they are not willing to wait, because the lymph node transfer takes quite a long time before you see the result. So it can take up to 2 to 3 years to see the result. So they need to wait for the regrowth of the lymph vessels. So after the proper conservative treatment, if the patient really understands the surgery, then we can propose it.
Okay. And in case you start with just liposuction and you see a good result in, let's say, a year or 2, would you go for a next step, like trying for curative intents to do a lymph node transfer?
I think mostly we do vice versa, so that if in the first hand we decide to go for liposuction, it's usually a case where we find that the curative intent is not
but if it works,
useful. If it so it's more, the question is whether or not the patient wants just to have a small surgery like lymphaticovenous anastomosis, or a larger surgery like lymph node transfer, because they are not comparable. The other one is quite big anesthesia, hospital stay, whereas the other one is local anesthesia. But it's like everything in life, the larger the cost, the bigger the result. So the patients have to choose between if they want a small relief from a small operation or a bigger from a big.
Okay. You mentioned about reverse node mapping. Do you do this on a regular basis? For example, when you harvest the flap to prevent from taking lymph nodes from the lower limb?
Yes, we always use this both if we use the thoracodorsal nodes for the lower limb, or if we use the inguinal nodes for the upper limb. We always use reverse sentinel mapping to make sure that we don't include any critical nodes.
Perfect. And you use a blue dye or indocyanine green for
we use
mapping?
Technetium.
Technetium for this.
Yes.
Okay.
So the patients have the injection the day before, and then we use the gamma probe in the surgery.
So like a standard for sentinel node.
Except they don't need to have any more the lymphoscintigram. They don't need to have the picture, just a simple injection.
Okay. Do your surgical oncologists who are doing let's say the breast surgery and axillary surgery beforehand, do they usually use a reverse node mapping, trying to prevent from further lymphedema? Some people think that reverse node mapping is one of the ways to prevent lymphedema.
At the moment, it's not in use in our unit. However, they are working quite a lot on trying to reduce the amount of axillary dissection. So looking at the tumor biology and quite often not doing axillary dissections, even if the patient, for example, has micrometastasis. So they use these nomograms for the decision making of the axillary dissection. So.
Okay, I see. Another question. Do you think is there any point of do some sort of prevention for lymphedema every time when you do a DF, for example, reconstruction on a patient who is otherwise in high risk for lymphedema? So a little bit of high BMI, a lady who had a radiotherapy or chemotherapy or something. Do you think it makes sense at the time of DF to make this extra anastomosis with thoracodorsal lymph nodes as a prevention of further lymphedema, not necessarily as a treatment, because let's say that the lady doesn't have lymphedema at present?
Well, there are some groups, for example, the group in Barcelona, which is advocating the use of so-called T-bar surgery, where they do a DIP with lymph nodes and a lymphatic anastomosis at an immediate setting during the cancer surgery. This, of course, requires quite a lot of surgeons in the cancer operation and takes longer time. So at the moment, I think it's time for us to wait for their results before we take that on, because you need more resources. So for the time being, we only use the lymph node transfer in patients who have some clinical evidence of lymphedema, and actually also will then have some potential benefit.
Okay.
So not in a prophylactic, it's not routine, it's still experimental.
Yeah. One more question, a more practical question. What is your post-operative regimen for this patient, for those with LVI and for those with lymph node transfer?
For both patients, we are lucky enough that our hospital is able to provide them with a series of 10 sessions of lymph therapy just to enhance the lymph flow, because I think in lymphatic anastomosis, it could be useful in the first couple of weeks to have as much flow as possible to prevent possible thrombosis of these very, very small lymph vessels. Otherwise, there is no consensus in the world about the postoperative treatment, but we don't allow the patient to wear a garment if a lymphatic has been done for 3 weeks, whereas in the lymph node transfer, it's just like any free flap. There's nothing really special. You can wear the garment normally, and it's more about the postoperative treatment of a DIP flap.
And do you use low molecular heparin in both scenarios?
Yes, but in the lymphoticovenous, I asked them to use it for 1 month because
Okay.
of possible thrombosis of the lymph vessels. But in lymph node transfer, just a normal 10 days or 2 weeks.
Mm-hmm. Okay.
But that is to prevent DVT.
Do you have any feedbacks from the patient, like PROMS questionnaire? How the patient feel like those type of procedure? A couple of years after the procedure, are they, let's say, happy that they went through this? Did they see the results?
Well, at the moment we're doing a study together with the University of Turku and looking back at our lymph node transfer patients for a longer follow-up. And in that study, we can see that most of the patients are happy, but of course, with time, we see that some of those who left out the garment will have a little bit of reoccurrence of the swelling. So I think for the time being, we don't know if the patient should still wear the garment at least occasionally or not. But and probably we don't know which patients we can allow to leave out the garment. But I can say that the patients are extremely happy after this procedure, but that doesn't necessarily prove anything.
Well, it's important from patient's perspective. You have to go through quite complicated and long surgery with long recovery and so on. It's really, we need to know that they're happy at the end. So looking back at your presentation, I just wanted to tackle one more thing about the risk factors. So you mentioned that the chemotherapy is one of the risk factors. Actually, what came from this year's American Society of Breast Surgery annual meeting, a paper from, well, it's presentation, it will be published later on, from Mayo Clinic in the States, based on almost 2,000 of patients. So basically what they found is chemotherapy, especially with taxanes, really increased quite a lot the risk of lymphedema. So if you compare chemotherapy with taxanes, the risk is 30% for lymphedema, and without taxanes, it's only 13%.
Yeah.
So the difference is huge. And also in their results, there were no difference between the type of breast surgery. With other words, lumpectomy and mastectomy doesn't make difference from their results. Otherwise, we historically know that mastectomy per se, even without auxiliary surgery, a little bit increased the risk of lymphedema.
Yeah, I think that my slide was from a recent Lancet review, but they probably didn't have these results then yet. But all in all, we can conclude that the worse the tumor, the bigger the risk.
Exactly. So the stage really is one of the most important determinants, and also the BMI, lack of exercise. So these are the things that I always underline to the patient, and I'm trying really to work on the things that the patient herself can change to make her daily life easier. So we're still waiting for questions from the audience, and I think almost our time is over. So I'll ask probably one more last question, and if we don't have anything from the audience, we can go to the end of our session. So you mentioned something about a preclinical lymphedema. The sensation when the patient usually describes as a numbness of their upper arm, or a feeling like a swelling. What do you do about it? Many patients have this problem, especially the first couple of weeks after surgery. Do we actually need to do something rather than reassurance? Or
I think in many cases, like I said, it's just a problem of the intercostobrachial nerves, in fact, and it's just a nerve damage that does that feeling. But we can differentiate those patients with a simple measurement device called the tissue water measurement, which is a small device called the moisture meter, which was actually developed in Finland, but I don't have any shares in the company. But with this, you're able to see whether or not in that specific area the amount of water in the subcutaneous tissue is higher than on the other side. So it's quite a simple thing that you can use in the outpatient clinics to tell the patient that, okay, here your water content is the same as on the other side, so no need to worry. So it's like an easy way in those cases to reassure the patient that there is no, but of course everybody will have postoperative swelling, so that's normal too. So I don't think you need to do anything in the first couple of months.
Usually inform the patient beforehand that this is quite expected. So after surgery, when they face something like this, they already know it's within the expected limits, and usually in most of the cases, it's really self-resolving. So nothing to worry about.
But these devices can sometimes detect like a subclinical early lymphedema, so they can be useful to find those patients earlier who might then start the conservative treatment also earlier, even if, let's say, they don't want to wear the garment in the daytime, maybe they can wear it at night and so on, try to prevent the swelling, because once the swelling comes, all the tissues get distended and it's more difficult to get it to go away. So prevention and early conservative treatment, of course, is the best.
Okay. So you advise people to start wearing the garments as soon as they notice even the little bit of swelling of the arm, or they can first try with physiotherapy?
I think it's quite useful to, if the people have some mild lymphedema, to have a garment available so that they can use if they are flying or doing some heavy work or so, to be preventative about it. But of course, not on a daily basis unless they really suffer, because it's not. We don't, of course, also not want to make the patients feel more sick than they are. So we don't want to worry them too much.
Okay, so I think I finished with all my questions, and we don't have anything coming from the audience. We are right on the time to end the session. So thank you very much for your presentation and for the answers of all the questions. Thanks to the viewers and thanks to IESO for organizing this. Don't forget, for those of you who are watching us recorded, that you can send questions via our website, IESO website, and me or Professor Suominen will answer you if you have any questions. Thank you.
And thank you, everybody. And thank you, IESO.